welcome to SCAI Conversations. My name is Andrew Goldswag. I'm the Director of Cardiovascular Clinical Research at Bay State Medical Center in Springfield, Massachusetts, and an Associate Editor of the Journal of the Society of Cardiovascular Angiography and Interventions, SCAI. I'm honored to represent SCAI and our Editor-in-Chief, Dr. Alexandra Lansky. You can find us online at jscai.org, that's JSCAI.org, on X or on Blue Sky at myJSCAI, on YouTube at SCAI-TV, on ViewMedi at JSCAI Journal, and on Spotify and Apple Podcasts at JSCAI Beats. JSCAI is the home of all official SCAI documents, and we're here today to discuss an important recent publication in JSCAI entitled Aortic Valve Replacement in Asymptomatic Severe Aortic Stenosis, a Systematic Review and Meta-Analysis. I'm joined by some esteemed colleagues here, internationally renowned experts. The first author of the paper, Dr. Philippe Généreux, interventional cardiologist and co-director of the Structural Heart Disease Program at Morristown Medical Center in Morristown, New Jersey. And Dr. Michael Reardon, cardiac surgeon at Houston Methodist Hospital, a TAVR pioneer who's really led this field from the high risk, intermediate risk, and low risk days, and now into this brave new world of asymptomatic patients. And by Dr. Islam El-Jandi, interventional cardiologist at the University of Kentucky and author of the editorial that accompanied the publication of this paper. So gentlemen, thank you so much for joining us. I'd like to begin with a question for Dr. Généreux. In this paper, you and your colleagues looked at 16 studies, including more than 5,000 patients with asymptomatic severe aortic stenosis. And amazingly, you found that aortic valve replacement was associated with changes not only in heart failure, but also in mortality. Would you summarize for everyone your group's findings?
Absolutely. First of all, thanks for having me. Thanks for the opportunity to share our work on behalf of my colleague as well. This is the manuscript called Aortic Valve Replacement in Asymptomatic Severe Aortic Stenosis. We did a review and a meta-analysis. And as you can see, a lot of co-author in this paper, which actually are all the principal investigator of the major randomized trial, plus other important co-author of multiple manuscript included in this effort. So as a background, we know AS is frequent and also symptoms are hard to extract from patient. It's very subjective. And we know that sometimes AS, and a lot of time actually, AS is progressive and it's hard to detect symptoms before mortality or morbidity happens. The current guideline and the guidelines are evolving, obviously, with findings and research. So the current guideline recommend clinical surveillance until symptoms occur for CDRS and no symptoms, or when EF drop below 50%. There still remains some debate about the optimal timing of CDRS no symptoms. And really the goal of this meta-analysis and review was to really inform whether a pool analysis of all the randomized trial and also all the observation and study already published can help us to identify the best timing of intervention. And this review was done, as a matter of fact, in the context of writing early TAVR trial. So we're trying to pull all the evidence together to try to have a constructive discussion around the finding of early TAVR and prior research. So this is the method. So it's a systematic review and meta-analysis using a standard methodology. We include all the randomized clinical trial and the observational study regarding the treatment of CVRS with no symptom, including TAVR, including SAVR, including all mode of AVR. We ended up with 16 studies, so 5346 patients, 12 observational study with 3919 patients, and 4 randomized control trials, so 1427 patients. And the randomized trial were namely early TAVR, which is the largest one with 901 patients, Avatar, Recovery, and Evolved. You can see that the mean age of the patient was around 71 years old, and the mean follow-up was 55 months, so pretty good follow-up. We're interested mainly in the all-cause mortality because we have more power than randomized trial that were smaller, but also look at other endpoints such as cardiovascular mortality, heart failure, hospitalization, or stroke. This is the main finding, and I would like to point out your attention actually to the first column of all-cause mortality. And what we did overall you can see that overall there is a reduction of 60% of mortality with early intervention compared to a strategy of clinical surveillance. And we also break down into randomized trials and the observational data. So you can see that when we take the observational data, there's almost 60%, more than 60% reduction in mortality with early intervention. But when we look at randomized trial data, we had a diminution of this effect, and then we have a non-significant reduction, approximately at 35% of mortality. And we can discuss why we see a difference between observational data, which is mainly real world, or in randomized trial that are maybe too good in terms of follow-up. We have the same phenomenon in cardiovascular mortality. Pulled together, we reduce cardiovascular mortality by 65%, but this effect was mainly seen in observational study. Interestingly, where we have a concordance of effect is by reduction, 70% roughly of reduction of heart failure hospitalization, effect present in both randomized trial and observational study. And in terms of reduction of stroke, we have a significant reduction of stroke by 40% in a randomized trial, maybe where adjudication of stroke is more robust, compared to no difference in stroke in observational study, where maybe it is underreporting, maybe even more in the surveillance group where maybe stroke are less detected or reported. So the key finding really is that take it all together, early AVR seems to reduce mortality, cardiovascular mortality, that for sure heart failure-related hospitalization and unplanned cardiovascular hospitalization. When we see in observational versus randomized trial, we can see that the benefit of mortality is really seen in observational studies, mainly that are more real world. And in the randomized trial, we didn't observe a decrease in mortality at the time of the follow-up, but there is significant reduction in heart failure hospitalization and stroke, which I think are very important. So I think in conclusion, that what is the clinical implication of those findings, especially in light of well-performed larger randomized trial? Well, I think that at the end, preemptive AVR or timely AVR for patients with severe no symptom at least improve heart failure hospitalization, improve stroke, and if you take in a real world setting or where the follow-up is not as optimal as a randomized trial, may improve mortality and survival, improve survival, both cardiovascular mortality and all-cause mortality. And I believe in conclusion that the overall message is early AVR in asymptomatic severity is important, will relate to improve an outcome, and we can debate, is it only restrict to heart failure? Is it only restrict to stroke? Does it involve all-cause mortality when the follow-up with symptom is too long, when we missed patients? And I think for sure the early TAVR trial and others show that there's a lot of benefit in early intervention. And in light of how difficult and practically challenging could be clinical surveillance in the real world, may be the preferred alternative or preferred strategy. Obviously, I believe I came from AHA, where the 10 years result of recovery trial were presented. Small trial in Korea, but still showing that there's a 50% reduction in mortality with early surgery compared to surveillance for severe AS no symptom, actually very severe AS. So I think this is pointing out that a longer follow-up of those studies will be important, and also a larger randomized trial will also maybe confirm the results. So I will stop there, and I'm open for a great discussion, Andrew, and panel.
Fantastic. Well, thank you so much, Philippe. This is super exciting. I mean, it's really a brave new world. We've always thought, at least I've always thought of TAVR as a therapy to treat an advanced disease condition, generally in older patients with comorbidities. And your work and your colleagues' work shows that TAVR may be appropriate in asymptomatic individuals, maybe more of a preventative or public health type procedure to begin early. I want to turn to Islam for a second. Dr. Algendi, we saw from what Dr. General just presented that there is tremendous value to AVR in patients with asymptomatic severe aortic stenosis. But many patients who are asymptomatic because they're young, they're otherwise healthy, they're well compensated for their aortic valve disease. in your editorial, you asked the question, should all patients undergo AVR once the echocardiographic criteria for severe aortic stenosis are met, regardless of their symptom status, right? Is this for everyone? So I want to ask you to tackle your own question, if you don't mind. Specifically, how does the rise of AVR for asymptomatic patients affect the lifetime management of this disease? Should everyone who has severe AS have AVR?
So first of all, thank you for the opportunity to be here among the panel and discuss this interesting article. And thank you for Dr. Gennaro for presenting his findings and along with his colleagues. And to your point, Dr. Goldzweig, it's a very difficult question to answer. So there is now strong evidence, both from RCTs and observational studies, to support an approach of early AVR. But like you mentioned, most patients who are asymptomatic with severe AS are usually younger. And with the uncertainty of the long-term durability of TAVR, we don't have data from randomized TAVR about the durability of TAVR valves beyond 10 years. It becomes a challenging question to answer. Certainly, some of the certain characteristics too or anatomical challenges were excluded from the trials, like patients who have small annulus. So I believe having an open discussion with our patients, along with a heart team approach, is very valuable in these scenarios, and to take into consideration what the patients would prefer.
So looking forward as to how to contextualize what we're discussing here. You both have been very active in the TAVR community for many years, have taken care of a lot of patients, and have conducted and led a lot of research. I want to ask you to look into your crystal ball here. Where does TAVR go from here? Obviously, aortic regurgitation is starting to come online as an indication, but what about asymptomatic moderate aortic stenosis, mechanical TAVR valves? Where are we headed with TAVR? Is there a limit?
I will let Mike. Why don't you put your surgeon hat and I will say your clinician hat, and you answer that first, and I will follow if I can your wisdom.
The limit is going to have to do with durability. If we had infinitely durable valves, then yes, we treat everybody as soon as they had AS, even moderate AS, because all AS hurts you. Even mild AS takes years off your life. And by the time you get to moderate, it's almost as bad as severe, whether you have symptoms or not. And so when I look at this, I ask myself, in an ideal world, you get through your life with no sternite, no hole in your chest. And the next best thing is to get through with only one hole in your chest. And so when you look at these asymptomatic people, I often ask myself, how young are they? Are they likely to get more than one more procedure? If I put a TAVR in them, is their root anatomy such that I can put a second TAVR in them? Or should I do an operation and do a root enlargement, put a big surgical valve in there so their next thing is going to be a TAVR? So each one of these things is individualized according to patient. But I joined a little late because I've got this pesky day job that heavy in the OR, my apologies. But I'm sure Philip told you that 50% of the people that were recruited into the study by expert sites had a class 1 or class 2A symptom indication for an AVR anyway. And in my practice, almost everybody that says they're asymptomatic, if you really test them, the vast majority of them are not really asymptomatic.
Absolutely. I think for me, the most exciting thing about those trials and randomized trial and observational study is we learn a lot about the disease. And we learn actually that actually severe AS is bad. We knew this. And now because we improve in AVR, TAVR, and SAVR, we know now that we can do AVR, SAVR or TAVR early on. And severe with no symptom is already too late. I think that's the consensus with all the randomized trial, whether you use TAVR or SAVR. And I think now we're going to have to sit with the heart team and use our judgment. If you have a 76 years old patient, are you going to use TAVR or SAVR? The same consideration, like Dr. Elgendim said, like you choose what is the best option for the lifetime management, acknowledging that the natural history of severe AS with no symptom within 11 months, you're going to be symptomatic anyway, and you may prevent crash and burn scenario. I think the moderate AS question is very interesting, and I think we are going to have 2 randomized trials next year that we're going to present for sure the progress trial and eventually the expand to testing the hypothesis if TAVR will be beneficial in patients with moderate AS with at-risk feature, meaning heart failure or moderate AS that smell like severe, that the echo is not able to say that severe or significant. So I think for me, it's all about the natural history of the disease. The enemy is not TAVR, is not SAVR, is the AS. And then the goal is to improve the outcome of our patient. And I think we need to come together. And I think there's never been a better time to be alive with AS than now, because we start to have option. We start to be able to prevent progression to a more severe and detrimental form of the disease. So I think it's an exciting time for patients and us to come together and to try to beat this disease.
I think early TAVR should say something else to our community, not just whether or not we should treat them or not, but if you're going to observe these people, get your CT now. So when they fail, it's already done. So if I'm just going to follow somebody, I get a TAVR CT. If they come back 6 months from now, 9 months, their CT hasn't changed, but they're ready to go. In the community, this can take months to happen. And so, I think one of the messages that needs to go out to the structural community and to general cardiologists is if you're going to watch and wait, you need your ducks in a row so that if they need to pull the trigger, you can pull the trigger now, and you don't have to go through all this other testing.
I always say that the two questions important is, first of all, you're waiting for what?
Yeah.
And second, how do you wait? Okay. And that's important. And when do you start? So for me, in my mind, you refer early, refer when it's moderate, you redo an echo after the patient would be severe anyway, because they're misclassified in community. And then if they're severe, you treat them. It's moderate, you follow them every 6 months. And then you're gonna optimize the management of AS and not only the treatment of AS.
We're talking about a new paradigm, I think, to address aortic stenosis. It goes something like this. A primary care provider hears a murmur, gets an echo, sees severe aortic stenosis, and refers the patient to a cardiologist, to a heart team. Does that patient immediately, from the echo lab with the severe aortic stenosis, go down a pathway of, we need to plan some sort of valve replacement procedure?
Well, who are you asking? Because if I have my own strong opinions as a surgeon, I mean, in an ideal world, they go to a valve team. That's not going to happen in the real world. In the real world, they're going to go to a general cardiologist first. And the general cardiologist is going to see them. And not all general cardiologists, I think, have the level of knowledge or the thought process that the cardiologists I'm talking to now do, because you guys are vested in this. This is what you treat. And most surgeons don't either. Most surgeons just wait for the referral. The problem is they need to get in with a group that really knows, like a valve team. But that's limited, quite frankly, to bigger cities and bigger institutions. I mean, if you get, 50 miles outside of Houston, you're not going to find people that have well-versed valve teams. You're going to find a cardiologist that, one or two that are going to sit down and talk about it. Their surgeons probably never read the data. But again, this is why the earlier we can get these in, I think AI is going to help this a lot along. All of us have these AI algorithms now that are flagging. We flag all AS, all AI, whether it's moderate or severe, and we send out a note saying, you should really consider sending this into the valve team and letting us follow with you.
I cannot agree more with Mike. Mike, we think exactly alike. I'm not surprised, but I think we're entering an era of screening and monitoring. And screening, there's a lot of education to do. I mean, people that believe that everybody knows the guideline is very mistaken, because like Mike said, in early TAVR, 50% of the patients that were sent for early TAVR claiming as severe as no symptom, 30%, as a matter of fact, 20%, as a matter of fact, already had a class 1 indication, low EF or symptoms. And then 30% had a class 2A, 2B. So people don't know the guideline. They wait until the symptom become manifest. So I think there's a big education to do. And I think screening starts when you have mild AS. And I'm not saying that we're going to treat mild AS, but if you have mild AS, it's not the same as having no AS. When you have mild AS, you're going to progress. And I think we need to follow them and then start. Why don't we start to do the dental clearance when it's severe AS the day before the TAVR? Dental care started with mild moderate AS or even before. But do a left heart cath way before. Do a CAT scan to know it's a bicuspid with a big aorta. This guy needs a surgery. And that started moderate. So I think we need to see those patients when they're at least moderate to identify the class 2B indication that already exists for surgery, that large aorta, coronary disease, prolapse, MVR, etc. And not wait until severe. It's obvious that the patient is the verge of a precipice, and then we play the superhero by doing a TAVR and acute valve syndrome and pulmonary edema. So I think for me, this is where we are in optimization and management with screening, monitoring, and AI would play a massive role. But education is key. I agree with Mike.
I'm sure, like me, I see somebody every week that comes in with really bad symptoms. They've been fainting for 4 months, and they weren't sent to me because the symptoms weren't too bad. And it's hard to say any symptoms are too bad. But they just say, they were, and they've been fainting for 4 months, and they finally make it in to see us. And it's just by the luck of the draw that they're one of the ones that's still alive. Again, the word needs to go out. Get these people in early to a team that really knows how to assess them. If they come into your team, get everything done. Yeah, get their teeth done. Get your CT done. And that way, when things go bad, you just treat them. I don't know about you, but getting somebody in to see my dentist is not an easy thing either.
No, it's painful. All those steps are painful, and this is real world. What we did in early TAVR was beyond good. Was not real world. That's why we mitigate mortality, because we were ready. CAT scan, teeth, and then actually, as a matter of fact, we find a lot of incidental, coincidental disease. We treat the lung nodule. We treat the kidney cancer. Now we bring them back in the trial. We were optimizing treatment of everything. In real world, is not like that. Especially, I came from Canada. If you go in geography like UK or France, it's difficult to get an echo. Sometimes take a year. Takes 12 months to get a CAT scan. So I think this is where reality hit hard, and this is where randomized trials are good, but maybe too good. And that's why we need observational data like what we presented to say, well, the truth is probably in the middle. But there's no benefit, zero to wait. That's for sure for severe AS.
Right. I think you've proven beyond a shadow of a doubt that starting early is not a negative, right? That there's no reason to delay. You don't benefit people by, as Mike said a second ago, waiting because the symptoms weren't that bad. I'd really like to thank Drs. Genereux, Reardon, and Algendi. We're thrilled to publish this important paper in JSCAI and to share this discussion with this incredible panel. To our listeners, please follow JSCAI. Submit your own work to JSCAI. JSCAI is the official journal of the Society for Cardiovascular Angiography and Interventions. You can find us online at jsky.org, on X and Blue Sky at myjsky, on YouTube at SCAI-TV, on ViewMedi at JSCAI Journal, and on Spotify and Apple Podcasts at JSCAI Beats. Thank you all very much.